Okay.
Is everybody ready to get started? Nobody needs their break. That's awesome. We'll power through, and then at the end, you guys can get going since it is Friday. Thank you so much for being here again. This is Dr. Siska from our pediatric endocrinology at Glennon, and I think quite a few of you, except for Glendale yet, and I don't know if you guys have one yet. You do have some strange metabolic issues. I don't think you have an adrenal insufficiency yet. But it's one of those things this is one of those issues we just don't train on in paramedic school. And so we brought her in so she can talk to you guys about it, because these are some of the stars you're probably going to encounter.
Yeah, so I've seen a couple of the star sheets on some of our kids, and most of them are hypopituitarism kids, so I'll talk a little bit about that, but specifically I'll talk about adrenal insufficiency. I talk fast and I talk quiet, so if you can't hear me or you don't understand, just let me know, okay? All right, so, wait, let me click here. Oops. All right, so I was just going to talk about adrenal gland physiology and interpretation of lab tests, the signs and symptoms of adrenal hypofunction, and kind of some emergency treatment protocols for you guys. So the adrenal gland is this kind of, we call it a tri-corner hat that sits on top of the kidney. It's made of 3 layers. So the zona glomerulosa is about 15% of the cortex, and this is the part that makes aldosterone. So aldosterone is responsible for our salt metabolism. So when we're looking at sodium levels, that's one of the things we're worried about. The middle part is the zona fasciculata, which is about 75% of the weight of that cortex of the gland, and that is involved with cortisol, or your glucocorticoid, and that's the sweet. And then the middle part is the zona reticularis, which makes your DHEAS. So when we talk about the adrenal gland, it's salt, sweet, sexy, so you remember which order it goes in, but I don't know if you guys really care about that. So regulation of adrenal gland function, it starts at the hypothalamus in the brain, which releases CRH, which is your corticotropin releasing hormone. That goes to the pituitary gland in the brain, which is a teardrop-shaped gland that sits right behind your eyes. So that's the master gland that we call in the body, though it's really controlled by the hypothalamus. But the pituitary gland is going to release ACTH, which is your adrenocorticotropin stimulating hormone, which acts on the adrenal glands and tells it to release cortisol. And so if anywhere in this axis is affected, then you're going to have adrenal insufficiency. So part of what I talk about the 3 layers of the gland is it's really controlling just this middle part, the cortisol. And so if you're not able to, if the brain isn't working, you can't make cortisol, which is going to affect blood pressure and glucose levels. But if the gland itself still works, you still have aldosterone being made, which is run by a different system. So you're not going to have as much of the low sodium levels that you'll see with dysfunction. So the adrenal gland has this massive biosynthetic pathway that starts out with cholesterol. So this is why you can't completely eliminate fat and cholesterol from your diet, because you need it to make all these hormones. Some of the problems that you might see have to do with where we have these different hormones throughout the pathway. They're all interconnected. I describe it to families, it's like a sink, and you have 2 sides to the sink, and you're pouring water in, and if you plug up one side and you can't continue on through that side of the sink, you spill over to the other side. So one of the things that you might see, none of them are really STARS patients because they're not in the complex care, but if you're picking up someone and the family tells you they have a history of CAH or congenital adrenal hyperplasia, it has to do with one of these enzymes that there's a defect in it. Typically, it's the most common one is going to be a 21-hydroxylase deficiency here, so you're not able to progress forward through these steps to make cortisol and aldosterone. So for this, you have a cortisol deficiency and an aldosterone deficiency. That's the most common. There's also an 11 beta, which you can't make cortisol, but you get backup of this 11 deoxycortisol and the deoxycorticosterone, which actually acts like aldosterone in very high levels. So they don't get the hypoaldosteronism. We'll talk a little bit about that too. So the mineralocorticoid, that's your aldosterone. So when I was saying previously that cortisol is strictly controlled by the hypothalamus and pituitary gland in the brain, and the aldosterone is run by a different set. This is having to do with your blood pressure and your your liver. So you guys know what ACE inhibitors are? Okay, so ACE is your angiotensin converting enzyme, which is going to be activated by renin coming from the liver, and then you're going to make use your ACE to make angiotensin 2 from angiotensin 1, which is then going to act at the level of the adrenal gland to make aldosterone. And you do this in order to control at the level of the kidney how much sodium you're holding onto and how much potassium you're getting rid of and what your blood volume is. So if you are having low blood pressures, you activate the renin-angiotensin system so that your kidney is not getting enough blood flow. And so you increase renin secretion, which then is going to get converted to angiotensin 1 and then get converted from your ACE to angiotensin 2 to then act on the adrenal gland to then tell the kidney, okay, hold on to sodium, get rid of potassium, and you're also by holding on to sodium, water follows it. So that's how you increase your blood volume or your blood pressure, because you have to have some electrolyte the water is going to follow to help you hold on to it. So if you have a problem with the adrenal gland primarily, you're not going to be able to make aldosterone. If you have a problem with the brain, you can still make aldosterone. The gland itself should be able to work to make the aldosterone. So you still get sick, you just may not get as sick if it's primarily the gland that's the problem. So the actions of ACTH on the adrenal cortex, it increases cortisol secretion by increasing its synthesis, so that's its primary action. So if we gave ACTH, it would immediately activate the adrenal gland to start making cortisol. You start taking cholesterol up from the blood. There are chronic effects of it, which means you get increased synthesis of most of the enzymes in the pathway, and you need this kind of chronic effect to maintain adrenal weight. So a kid who has hypopituitarism, meaning that the pituitary gland doesn't work in the brain, they can't chronically stimulate their adrenal glands. So those adrenal glands over time atrophy and get really small, and so then you lose that ability to make aldosterone as well. So some of these kids will end up being somewhat aldosterone deficient, even though the gland itself should work in theory. So what do glucocorticoids, or the cortisol, specifically do? So it pretty much affects everywhere in the body. The big things that you really need to know about. So the liver, it's going to stimulate gluconeogenesis and glycogen breakdown. So if you have a kid who's hypoglycemic, this is one of the things that you would think about. Are you able to get sugar out of the liver? Are you not able to due to glycogen storage disorder? You're not able to store glucose, you're not able to get it out, or is it that you burned through all of your stores, or you're not able to stimulate it to happen? So with adrenal insufficiency, part of the issue is that you don't have cortisol to stimulate the release of sugar from the liver. Does that make sense? Okay, so with that, these kids can present with hypoglycemia, and we'll get to the presentation, the clinical part of it soon. It can also activate the muscles so that you can get amino acids out of the muscle, and amino acids can get turned into glucose or energy equivalent. It also has effects on the lymphoid tissue, the skin, and the fatty tissue. So this is not an emergent case, but it highlights a lot of the stuff. So this is a 16-year-old boy who presented with weight loss and fatigue. He had decreased appetite, fatigue for about 6 months, was losing weight. For the last 2 months, he was intermittently nauseated and vomiting, and now he's had dizziness and weakness. He's really had an unremarkable past medical history, and we'll get to the family history. So he was kind of tired, mildly ill appearing, but his blood pressure, you can see, is low for a 16-year-old at 78/44. He's tachycardic, and he had a really slow cap refill. And his skin was this muddy brown color, and he had hyperpigmented patches on his tongue and gums, and he was fully through puberty. So, I mean, we would essentially treat this kid as an adult. So when he got his studies in the ER, his sodium was 127, his potassium is 6.2. I think you can tell that's fairly abnormal, not the worst that I've seen, but and he was a little bit acidotic with a bicarb of 16, and he was hypoglycemic with a glucose of 56. And so for the endocrine labs, appropriately got a cortisol, which was undetectable. So some of the features that you're going to see with adrenal insufficiency are going to be these symptoms that, you know, they're nauseated, they're dizzy, they're lightheaded, they haven't really been eating, they've been losing weight. The hyperpigmented patches, or the muddy brown color of the skin, is suggestive of primary adrenal insufficiency, where the gland itself doesn't work, because your brain is trying to tell the gland to work. So it makes a lot of ACTH, and ACTH is going to come from a molecule that also makes melanocyte stimulating hormone, and so you get hyperpigmented. So have you guys heard that JFK had Addison's disease? So, and he always had this healthy tan. But it's not really healthy. It's this kind of, you're tan colored, you're brown colored, but it's kind of pasty. Like, you look sick under it. You don't have that kind of healthy pink glow under it. It's this kind of like muddy, pasty brown color. And you just get hyperpigmented everywhere. And what I tell the students and residents is you have to look where the sun doesn't shine. And if they're dark there, that tells you there's something abnormal. So typically, like if you're seeing it in their axilla, the nipples get really dark. They're darker around the genital region. I usually look at the bottoms because most people don't bare their bottoms to the sun, and if their bottoms are fully dark, you're like, oh yes, this is what you have. So that suggests that it's primary. Now, if the brain doesn't work, you don't get this muddy brown color. But then they're going to be hyponatremic, and they're going to be hyperkalemic, and they can be a little bit acidotic, and they can have low blood sugars. And this is because cortisol is a counter-regulatory hormone. So when you're sick, you need cortisol to help stimulate your immune system to start working, and then you also need cortisol to help release glucose from its stores in the liver and in the muscles. So if you're not able to do that, your blood sugar is just going to keep dropping. And then you're also, if you have adrenal insufficiency, you're not able to make aldosterone, so you can't tell the kidneys to hold on to sodium. So you're losing sodium, so your sodium level drops, and your potassium level goes up, because that's the trade-off. You either hold on to sodium or you hold on to potassium. And so that's where you get those two things. And then you're hypotensive because you're not able to hold on to water along with that. So he had primary adrenal insufficiency. So common causes of this, most commonly we see autoimmune adrenalitis or Addison's disease. Everything else is pretty unlikely, and usually they'll probably have already been diagnosed if there's a peroxisomal or lysosomal disorder. So these are usually genetic syndromes. I have a couple kids that I follow with peroxisomal disorders that were diagnosed with genetic testing because they had weird stuff, and they're like, well, you have a mutation in this gene and we don't know what that means. So we just kind of monitor their adrenal gland function and wait to see what happens. There could be infections. If there's trauma and they have hemorrhage to the gland, they can have that. So if there's a car accident and you have a kid who's they're hypotensive, they're hypoglycemic, and they've had abdominal trauma, you want to think about, has there been a hemorrhage, and that's why it's not working. So sometimes giving steroid can help. Usually they get to that by the time they're in the PICU, where they're like, oh, yeah, we have them on all these pressors, and nothing's working, so let's get a cortisol and give them steroid. It usually ends up being down on the list. So this kid had an undetectable cortisol, and his ACTH level was greater than 2,000, which you probably don't need me to tell you that's abnormal. And then he had positive antibodies to 21-hydroxylase, which is the enzyme in the adrenal gland that's in that pathway. So when he initially came in, he got 4 liters of normal saline over 3 to 4 hours. He got an IV dose of hydrocortisone, and he got some oral fludrocortisone. Fludrocortisone is the equivalent of aldosterone, and it's only available orally. There's no IV formulation for it. This is a kid who got discharged from the ER after 6 hours because he had improved all of his electrolytes and blood pressure. And this is because with the family histories, his mom brought him in. She's like, he has Addison's disease. His dad has this too, and he nearly died last year or so. So I like this because I always try to remind myself when I'm seeing a kid to listen to the parents, because the parents know the kid better than I do. So if they tell me there's something wrong, I try to listen to them and keep that in mind, that like, okay, like this is not normal. They're not acting right. So the second case, this is a little kid, a 3-year-old boy who came in with hyponatremia and hypoglycemia. He had been doing okay, but he had intermittent abdominal pain and vomiting, but the vomiting persisted, decreased intake. He stopped peeing because he was dehydrated because he wasn't drinking anything, and he was listless and progressively weaker, and then he got really confused and extremely weak. So most of these kids that come in, they probably are just like, oh, you probably have a gastroenteritis, it's viral, like if you're sick enough, you get IV fluids, you get sent home. But this is a kid who, like, this has been going on. He was really sick coming in, and he had this history of salt craving. So why do you think you have salt craving? Like, if you've got gastroenteritis, you typically don't have salt craving. This is if you have aldosterone deficiency and you can't hold on to salt. So these are kids who, they'll get into the fridge and they'll drink pickle juice out of the jar. I mean, they're just like that much salt. And has anyone drank pickle juice before? It is horribly salty. And you just, like, you only want it if you're really that salt deficient. And so the rest of his history is really non-contributory. He was very he was unresponsive and dehydrated. He was very tachycardic, and his sodium was all the way down to 110. His potassium was 6.5. His chloride was low from the vomiting, and his bicarb was 7. So he was very acidotic, and part of that is just this ongoing illness. And then he got a bunch of fluids, got admitted. He was still lethargic, but they didn't really notice anything else except the dehydration. So continuing on, after he had been treated with lactated Riners, his sodium was only up to 116, but his K had come down, and his blood sugar had shot up to 185. He had low, he had kind of a mid-range urine sodium because he was still peeing it out. He had a kidney ultrasound that was normal, but his cortisol came back at 11.8 when he was initially seen at the outside hospital, which it's not great for a kid who's that sick, but it's not undetectable. So you're kind of like, is this really adrenal insufficiency or not? But it turned out that his aldosterone level was undetectable. So this is a kid who really just had aldosterone deficiency. And so you kind of look at, again, is it primary adrenal insufficiency? Is this from the gland itself not working? And again, it can be from autoimmune disorders. You can have an infection, you can have trauma, different drugs can affect it. But the secondary type is where, and that's what this kid had, is it's from the brain. So primary adrenal insufficiency, we say it's the gland itself that doesn't work. So that's the primary part. Secondary is you're not getting the message from the brain to tell the gland to work. And so that's usually, you're thinking about, do you have a tumor, or do you have brain trauma, or were you born with a congenital defect? Okay, so how do we evaluate for low cortisol levels? So we do an ACTH stimulation test, and so we give exogenous ACTH. So we measure a baseline cortisol level, we give a slug of ACTH, and then we get a cortisol level after, and we say, do you respond? So if the adrenal gland itself doesn't work, what would you expect your cortisol level to be after you give ACTH? Unchanged, right? 0. Like, it doesn't respond. If the gland itself works, what would you expect? It should go up, right? So this is where endocrinology gets kind of fun and kind of tricky. So when we try to figure out, is it primary or secondary, if it's the gland itself, it doesn't work, your cortisol levels are undetectable. They're less than 1. You don't get anything. We can do low dose and high dose testing. And then if it's the brain is not working, so if you recall, I had said that you need that kind of chronic stimulation from the brain of ACTH to tell the adrenal gland to keep making cortisol, because you always need a little bit of cortisol. Everybody gets a big slug of it in the morning. It's what helps us get up. It's like a morning cup of coffee. And so if you're not able to do that, the gland itself kind of starts to atrophy over time. But if it hasn't been going on for a long time, your gland is still there and should work. But if you give just a little bit of ACTH, like a low dose of it, you don't really stimulate up. But then if you give a high dose, you just give a huge whopping dose of ACTH, you're going to get that gland to stimulate up. And it usually stimulates up to an appropriate level. So that's where you can kind of determine, like, okay, the gland responded to the high dose but not the low dose, so that tells me it's the brain that's not working, versus it didn't respond at all to the high dose. That tells me the gland itself doesn't work. Does that make sense? So the gold standard used to be we do an insulin-induced hypoglycemia test or an insulin tolerance test, which means we would just give people insulin until they went hypoglycemic. And then you check all their labs and then be like, okay, let's give you a bunch of sugar to bring it back up. not an ideal situation to do. Lots of seizures used to occur in these kids who would get tested. I luckily never had to do them, but my colleagues, that's all they did in their fellowship. They're like, that's all we did were insulin tolerance tests. So I did my training in the age of synthetic ACTH, so I didn't have to do that. So it's much better now. Presentation of adrenal crisis, this is the stuff that you guys are probably more interested in. So if they're hypoglycemic, they're hypotensive, if they've been vomiting, they have altered mental status, loss of consciousness, seizures, shock. These could all be from multiple different things, but you really want to think about adrenal insufficiency in particular if the family's giving you a story that doesn't make sense or fit with their current illness. So the biggest thing is if it's out of proportion to the severity of their current illness. So it's kind of like, yeah, my kid was sick, like they had a fever, it was 101, but then they started vomiting, and now they're just like, they're not really responding, they're really lethargic. Something that goes that quickly, you're kind of like, something doesn't feel right about this. You want to think about adrenal insufficiency. Now, if you have some of the diagnoses that you might, if a family throws out any of these kinds of things, you want to think about it and specifically. I mean, if they tell you, my kid has adrenal insufficiency or Addison's disease, they could have adrenal suppression, adrenal withdrawal. If you get a history that they've been treated with anything for with high-dose steroids, so they have asthma and they've had a bunch of courses of oral steroids in the last month, or they've got some sort of autoimmune disorder like Crohn's disease or ulcerative colitis or rheumatologic stuff like rheumatoid arthritis or lupus. If they have really severe eczema, like their whole body is covered in eczema and you know that they're using topical steroids, and then you're getting called for a kid who's lethargic and hypotensive, you want to think about maybe this is an adrenal insufficient patient. And then if they have hypopituitarism, so these can be deficiencies in, can I move this thing so you guys can see it? I don't know if I can. There we go. So if they have deficiencies, ACTH deficiency, so they're going to have cortisol deficiency, they're growth hormone deficient, TSH deficient, or LH or FSH deficiencies. And then if they have hypoglycemia, you want to think about cortisol deficiency. Yeah. Okay, so hypopituitarism, so that's loss of function of the pituitary gland. This can be congenital or acquired, and it may be that you're deficient in one, multiple, or all of the pituitary hormones. So the pituitary hormones that you'll see or be worried about that we actually replace, so if there's ACTH deficiency, so that's cortisol deficiency, so you're not able to make cortisol. Growth hormone is another one of our counter-regulatory hormones, so we do have a number of patients who are growth hormone deficient who have recurrent hypoglycemia in infancy until you start treating them with growth hormone, because growth hormone also stimulates the release of glucose from the liver and muscle. TSH deficiencies, you're probably not going to get called about unless they haven't taken any of their medicine forever and they have what's called a mixed edema coma. But typically that takes a really long time to get to that, and it's not, I think I've seen it once. So if they're on thyroid medicine, you want to think about it. LH and FSH, these are gonadotropins. These control puberty, so estrogen and testosterone production. Typically, you're not going to have any emergencies with deficiencies in that. And then ADH is your antidiuretic hormone. So this is important because ADH is what tells your kidneys to hold on to water. So if you don't have ADH, you have diabetes insipidus or DI. So different than the diabetes that most people say they have, which is diabetes mellitus. And I probably could have done a whole separate talk on the DI kids. But so with diabetes insipidus, these kids can't hold on to water. So if you're peeing out all your water, what happens to your sodium level? So it actually goes up. So if you think about, you've got a container full of water and you put marbles in it. If you drain out the water, the marbles get all concentrated together down at the bottom. So that's essentially what happens with diabetes insipidus. You pee out all your water, so your sodium concentration, it gets more and more concentrated. So these kids have high sodium levels, but they get very dehydrated. And so these kids can get into trouble from the hypernatremia, though hypernatremia is less bad for your brain than the hyponatremia or low sodiums. But a lot of these kids, there are cases of just isolated diabetes insipidus, but if a kid has diabetes insipidus, they probably have a deficiency somewhere else in the pituitary gland as well, so you want to think about cortisol. So this is just kind of a another image with the pituitary hormones, and again, kind of talking about like what the symptoms are that they can present with. So with ACTH, that stimulates your adrenal gland to make cortisol, and symptoms of deficiency are hypoglycemia, vomiting, lethargy, malaise, and then when you guys get there, you can find out that they're hypotensive as well. If you have TSH deficiency, you can't make thyroxine or thyroid hormone, so these kids are just really tired, they're cold intolerant, and they have bradycardia, and they can be kind of edematous, but it's kind of like a tense edema, it's not a squishy edema. If you have LH and FSH deficiency, you're not making estrogen or testosterone, so delayed puberty and those kinds of things. Growth hormone deficiency, they can have hypoglycemia and they have short stature. And then ADH is your antidiuretic hormone. So these are kids who are peeing a lot, they're drinking a lot, they're hypernatremic, and they can get really dehydrated. So some home medications that should kind of tip you off that, hey, this kid has some issues. If they're on hydrocortisone or Cortef, prednisone, prednisolone, dexamethasone. Most people aren't on methylprednisolone. And then if they're on fludrocortisone or Florinef, that's our aldosterone equivalent. And then medications that might suggest hypopituitarism would be growth hormone or DDAVP. So the DDAVP is your replacement for your ADH. So stress dose steroids. So this is kind of the big thing. So if someone has a diagnosis of adrenal insufficiency or there's a history of prolonged exogenous steroid use, you want to think about giving stress dose steroids. So the issue with stress dose is when you are adrenally insufficient and there's something that stresses your body. Now this is physical stress, not psychological stress. This comes up a lot with our families. Like they're like, oh, my kid has finals this week and I needed to give them stress dose steroids. No, it's not psychological stress. It's physical stress on the body, which is going to be if you have a fever, typically we say greater than 101. If there's vomiting, diarrhea, or they're just not eating, they've had decreased oral intake, that's a stressor to the body. If there's a traumatic injury, so if they broke a bone or they had a bad burn, that's stressful. If they've lost consciousness, they're hypoglycemic, they're hypotensive, or they're in shock, obviously that's very stressful to the body. So again, cortisol is what's necessary to help stimulate the body's immune system to fight off infection. It helps maintain normal blood pressure and normal blood sugars. So if you're not able to make that, if you get sick and you have a fever or you're throwing up, your body isn't able to utilize the stores of sugar that you have and isn't able to help maintain perfusion. So you can very quickly go down the drain. So if you are called to a kid who has been sick and you know that they have adrenal insufficiency, if you think you may need to give a stress dose, just do it. You're better off, you're going to cause less harm by giving them a dose of steroids if they didn't need it than if they needed it and you didn't give it. And that's the rule that I tell all my families. If you think you need to give stress dose, just give it and then give us a call afterwards, because I'm usually going to say, just give it. You're going to feel better if you give it. So, different steroids have different potencies. So we typically use hydrocortisone as the kind of the main one that we use. Hydrocortisone really only lasts 6 to 8 hours. It says the half-life is 8 to 12, but it's more like 6 to 8. And then prednisone and prednisolone are going to last closer to 24 hours, as is methylprednisolone, which is solumedrol. Trish, you said that you guys have solumedrol.
Most of our units have solumedrol. I don't believe the Mercy ones do. Scad, do you guys carry steroids?
Not at all.
SSM districts carry solumedrol.
Solumedrol, okay. And then our families, we use...
Oh, Yandex?
You have Dex?
Denise has solumedrol and Dex.
Okay, yeah, and so we use dexamethasone because that half-life is like 24 to 36 hours. And so the reason why we like the Dex is, and we have our families have dexamethasone, or they should have it at home to use in emergency cases. So typically when we give a stress dose, we give our families instructions. So if they're fever, vomiting, diarrhea, they're supposed to give oral stress dose initially. And so the oral stress dose, we look at their total daily dose of steroid, and we just tell them, take that amount, like your total daily dose. So if they're on 5 milligrams twice a day, they'll take 10 milligrams at that time, and then we have them do that 3 times a day or every 8 hours. So obviously if you're having an adrenal crisis and you're vomiting, you give an oral dose, you throw it up. So then the families always say, well, what do we do if they throw it up? We say, well, depending on how sick they look, if you want to wait half an hour, try giving it again, or just go ahead and give the injection of dexamethasone. So what's nice about the dexamethasone is since it lasts 24 hours, they're covered for 24 hours. They don't have to do it again. If you guys are picking up some of the other, like patients from the other children's hospitals, I know St. Louis Children's gives their patients Solucortef. Solucortef is good for 6 to 8 hours. So if they've given a dose of that, within 6 to 8 hours, they need another stress dose of steroids. So that's why we like the Dex, because then we know they're covered for long enough. Oftentimes families will give the Dex while they're waiting for you guys to get there, so you can ask them if they've already given it, or if they haven't given it yet. You can say that, like, can we give it, or do you want to give it? We usually try to have them give that while they're waiting, so that gets in, and then usually that helps tremendously, and the kids turn around pretty quickly. The action time for the onset of the IM Dex is pretty fast, so they do tend to do okay with it. Now, talking about aldosterone deficiency versus cortisol deficiency, one thing to note, dexamethasone really doesn't have an aldosterone effect. All the other ones will if you're giving it in high doses. So if you're giving stress dose coverage, a kid who has primary adrenal insufficiency, such as Addison's disease, they're going to get this high dose of hydrocortisone. That's going to kind of cover what they need for that aldosterone effect, but with the dexamethasone, it doesn't cover them, so I do tell the families to still take the fludrocortisone on top of it if they need it.
Do you recommend transport for these kids to the ER or just to contact?
So it depends on how sick they are and kind of what happened. Some of these families, like some of them are really good, and they usually call us and say like, hey, this is going on, and I'll say like, give them Dex. If they're not looking better in half an hour, bring them into the ER. If they've called you guys, generally it means that they don't know what they're doing, and so I usually recommend that they go in to get evaluated, just so that then we can make sure that, the blood sugars come up, blood pressure's up, and what caused it. Like if we have a pretty clear picture of what caused the adrenal crisis, then they may not necessarily need to go in. And there's always a physician on call with our group, so if it's one of our patients, just call us through the access center. Most of us are nice, I think. So, and it's usually just like, hey, we're seeing this kid, and usually the parents are okay about going in. If they were scared enough to call you, they're going to want to go in and get evaluated. Every now and then you get these families who are like, I'm not going in. Like, you're not taking me there. Just call us and we can kind of figure out what needs to happen for them. And if there's some families that we know, like, oh, they're bad actors, just bring them in, tell them they have to come in. And then we've got families that were like, oh, this is a really good family, I've already talked to them, or why didn't they call me? They should have called me. No, but usually we kind of take it on a case by case. So, but if they're sick enough that they called you, they probably need to come in. And usually it's just they've gotten to the point where they're so dehydrated that they probably need to come in to get IV fluids anyway. So, so steroid doses, I should probably like copy this and email this out to you guys for, I kind of went through. So we have, typically our hydrocortisone stress dose is based on body surface area. Most of the time you guys aren't going to have a height and a weight on a kid. So we kind of use just like based on age for our dexamethasone dosing. So that's in the middle. So our families have a liquid preparation of dexamethasone that they can give, and it comes as, 1 milligram is 0.25 mils. So it's 4 milligrams per mil. And so if they're over 10, we just give 4 milligrams of Dex. If they're 4 to 10, we give 2. And if they're under 4, we give 1 milligram. And those about work out for body surface area dosing. So your dexamethasone is between 30 to 50 times as potent as your hydrocortisone. So hydrocortisone is kind of the main one that we use. So when kids are in the hospital, we put them on Solucortef. But so if you guys have Solucortef, this would be the dosing that you would use based on age. Because this way, that's a lot easier than trying to say like, well, I think they're about this big, or because what are those little charts called that you kind of like? Thank you. Yeah. So yeah, I mean, you could kind of guess, but this works just as well. It's about equivalent to it. And then for the Solumedrol dosing, it would be like 5, 10, or 15 milligrams. So I can email that out to you, and you can pass it on.
Something you'd be comfortable with me listing the Solumedrol dose, those age ranges for?
I think so. I should probably get everyone else in my division to say like, yeah, that's fine.
Okay.
And then I'll email it out
If
to
you
you.
do, then that would be great. And then
Yeah.
Dr. Laffey too, since he's our medical director.
Yeah, and we'll see if that works. Because then if you guys have that, is that's a nice, easy, quick and easy. And then you just have to know the age of the patient. And so, and as I said, the big thing is if you think you might need to give a stress dose of steroid, especially if the kid has been diagnosed with adrenal insufficiency, just give it. You know, that they're going to get better faster if you do, if they needed it. And if they didn't and it doesn't make a difference, then there's something else going on, and then that gives you more information as well. So other treatment considerations, just the hypotensive. Oftentimes they need multiple fluid boluses. And usually what happens is like, yeah, we're on the 4th fluid bolus for this kid and they're still not getting better. And then that's when they're like, oh, we should check a cortisol. So if you think about it ahead of time and you get the steroid in, you're not going to need to give as much fluid. And then oftentimes they're hypoglycemic, so you'll want to use fluids with dextrose in it. So I don't know if do you guys carry LR? Yeah.
Some carry LR,
Or some
carry D10.
D10, yeah. So either of those work fine, or sometimes it's just you're given an amp of D50. Usually for kids, I do 2 mils per kilo of a D10 bolus to get them up. So then it's kind of like you can do the equivalent math for whatever you have on there, but usually it's just you're giving an amp for these kids. Now, depending on what the cause of the hypoglycemia is, if it's adrenal insufficiency, they'll come up, and then if you give the steroid, they'll bump up further. If you don't give the steroid, they're going to come back down because they're not going to be able to utilize it or to continue utilizing it. I think that was my last slide. So do you guys have questions or want to just like run through scenarios? I think we've got a little bit more time. Yeah.
We have a couple of kids in our area that are adrenal kids, and I know that on their forms they have orders for soluble Cortef, but we don't carry it. I imagine they have they have it at home.
They should if they have it.
If we were planning as districts to get a steroid, we'd be more likely to get something like Solumetral where we could use it for multiple protocols. Is that going to be adequate in an emergency if Solucortef is not available?
Oh yeah, yeah.
Can we give Solumetral?
Yeah. So and the Solumetral is that's the methylprednisolone, and so it's kind of like in between potency for hydrocortisone and the dexamethasone, and so the Solumetral would absolutely work. So, and it's more, it's just kind of
board, or is it just
across the board, yeah. So all of these steroids, I mean, they're all going to be having the same action. It's just a question of how strong is it, so how big of a dose do you need to give? And oftentimes the Solumetral doses that are being given to kids in the hospital, I mean, they're giving huge what we're trying to do is physiologic replacement. And so oftentimes you'll have these kids who are on, they're on prednisone 60 milligrams a day. That's huge. That's way higher than what we would use for physiologic replacement. For physiologic replacement, they probably need like 5 to 10 milligrams per day, and then their stress dose would be 10 milligrams every 8 hours. And so to give 60 milligrams, you're giving supra-physiologic doses. So if you have Solumetral, you're probably going to be given higher than the 15 milligrams for most of your protocols. And so if a kid has adrenal insufficiency, that would work. So if they have a prescription for Solucortef, you can use the Solumetral. It would be a little bit lesser of a dose, but you probably wouldn't be wrong by just giving Solumetral at the equivalent dose of their Solucortef. So, it's like their Solucortef is written for 25, you would give them 5 milligrams, but if you gave them 25 milligrams, they got a higher dose of steroid. So long as that's not prolonged and repeated, it's not gonna cause undue damage in that moment, and you're actually going to be doing them. You're going to be better treating them by giving them the steroid than by not. And with the Solucortef, those vials are really irritating because you have a powder and a liquid that you have to mix up. And they used to make these nice little quick ones that you just like push it down, but they don't make them anymore. So I don't know what most families have.
Solumetral is separated and
And yeah, and you quick them together. Yeah, the dexamethasone is just a liquid. That's why we use it, because it's much easier, especially in an emergency situation for families. Like they're just much more comfortable being like, okay, just draw it up. And for our diabetes patients, we use glucagon, and trying to talk them through how to mix up the glucagon is always fun. And then they look at that needle and they're like, you want me to give it with this? So I tell families to tape an insulin syringe to their glucagon kits because you can give it sub-Q for glucagon. These ones are going to be IM. I didn't put that on here, but this is all IM. It could be IV too. I mean,
That's why questions I've gotten is if they have an IV, would it be more effective to push an IV, or should it always? Okay.
yeah.
I always get questions about onset.
Yeah.
Because if they have this, and I think you said it was a pretty quick onset,
Yeah.
because a lot of the reason the ambulances don't carry steroids is because of giving the higher doses for respiratory type issues. And our medical director is always like, oh, it's the onset's so long and you don't get in the acute setting. So when we talk about this, I'm like, why would it work that fast? They don't understand.
Yeah, this one, for the adrenal insufficiency, like the sooner you give it, the easier your management is going to be, just because they respond so quickly. So if you give it IV, they're going to respond much faster because it's in the bloodstream, as opposed to when you're giving it IM and you're already hypotensive and dehydrated, your perfusion is low, so it's going to take longer to absorb it IM. So if you have it IV and you have access, you can give it IV, and you can give any of these IV.
Exact same doses.
Mm-hmm. So, and then in terms of, so dexamethasone, and I can fix this to put IVIM, and then like repeated doses, because like the hydrocortisone, you would want to repeat that at 6 to 8 hours. Hopefully you guys aren't still with them at 6 to 8 hours. The dexamethasone is good for 24, and the solumedrol is good for 12 hours.
Awesome. That's it. I always get asked that too. Do we ever have to repeat it? So I'm like, I don't think so.
Generally you don't. I mean, once you give it, they usually respond pretty quickly. Kids who are initially presenting with Addison's, they usually need stress dose steroids for several days before they really start to feel better. But once you get that initial dose in, they're kind of like, oh. You know, they really turn around within a couple days. Kids who have had long-standing adrenal insufficiency and they get sick for whatever reason, they usually feel much better once you start. So the presenting symptoms, usually it's something like they get a fever from a viral illness, and then the vomiting starts later. It's not necessarily a vomiting illness or a gastroenteritis. They start vomiting because of the adrenal insufficiency. And so then once you give the steroid, the vomiting stops. It doesn't treat the actual illness, so they're still sick, but they're going to feel a lot better, and then they can actually tolerate taking stuff by mouth because they're not vomiting and feeling nauseated anymore. Kids who haven't been diagnosed, the onset of adrenal insufficiency can be very insidious, where it's this kind of just slow, like they're tired, they're like sleeping more, they're kind of, you know, like, yeah, they're just not eating much, they complain of intermittent belly pain. I had one kid who got diagnosed with cyclic vomiting for like a year before it, and GI they sent him down to get scoped, and I get a call from a resident. They're like, yeah, he's getting an endoscopy right now, but do you think it could be adrenal insufficiency? I'm like, oh my God, don't let him get anesthesia. That's going to precipitate a crisis. So yeah, it's just one of those things that sometimes people don't think about it. So I think with these patients, the STARS patients, you guys are going to have that, like, this kid has adrenal insufficiency. If you're getting called, if the parents haven't given steroids, you should just give steroids off the bat.
And that's what we're trying, most of our kids, they're identified, no. We've had a couple before STARS. We've had a couple bad cases where that one person wasn't home, and that seems to be all the cases for our complex kids. Is think we can. Mom's the expert, dad was there, grandma, and it ends up to be a crisis.
Yeah. And
they're rare, but it's happened, and they end up being call reviews. And when the medics are typically told, oh, we have a steroid, they're like, a steroid to fix this? No, you know, it's just something that doesn't cross their mind, and it hasn't been given, so it's been a big delay in treatment.
Yeah, and I've been trying, I never have time to do the things I want to do, but I really, when I did my training, we had little cards that we gave out to families, and like bigger, you know, like a half sheet card and then little business cards that had like, I have adrenal insufficiency. We would write their doses on there so that they could bring it into the ER if they were called anywhere. And it's kind of like, you have, it's like a medical alert basically, but it had the instructions on there, which is like, if you have these symptoms, take this dose of steroid. If you're not tolerating oral, give this injection. And then it had like our contact number on there so that people could call us, you know, and having something like that.
Kids you're worried about, you know, definitely send them my way, because it'll be formal and dispatched on a plan, and it won't be missed.
Yeah.
So it'll be attached to them.
Yeah, yeah. No, I'll have to, I know we have a couple that, yeah, they're like CAH or just adrenal insufficiency, so I'll have to send them to you, because there's one I got called about a couple calls ago, like 2 months ago. I was like, oh, why do I know this name? Oh, right.
Yeah.
We talked about you at conference, and you don't come in.
Or
and
school, you know, you think someone could potentially have an issue at school. And,
Mhm. Yeah, having those things at school. Yeah.
Yeah, that would be
Yeah.
helpful, I think, for them. So.
Yeah. No, since this was kind of a hodgepodge of stuff, so and hopefully I didn't confuse you more.
Thank you very much. Anybody else? Thank you.
All right.
Thank you.